Hello, my name is Jean-Jacques Kiladjian. I'm a hematologist in Saint-Louis Hospital in Paris, France, and I will discuss today the curative options for myelofibrosis. In fact, there are several obstacles toward cure of this disease. First of all, the disease complexity itself. As you know very well, there are three main driver mutations that were discovered more than 10 years ago now, namely JAK2, calreticulin, and MPN mutations. But beyond these driver mutations, many others have been discovered in the past decade that can be associated either in the same clone or in an additional clone. So now that we have very powerful techniques to dissect the clonal complexity of diseases. For example, we have single-cell sequencing, and we found in several of our patients using this new technique that in the same patients could coexist more than 10 different subclones or clones, different clones with several combination of mutations or even different mutations. So to compare, for example, to CML, which is also a myeloproliferative neoplasm, the disease complexity here is much more important at baseline, explaining sometimes the difficulties to treat these patients. So these are more oligoclonal or even sometimes polyclonal diseases rather than purely monoclonal diseases. Second, this clonal architecture may change over time, and there's some dynamics of these mutations that can be shaped also by the treatment we propose to these patients. For example, we have shown that TP53 mutations could be selected by treatment with hydroxyurea. In contrast, DNMT3A mutations could be selected by interferon alpha therapy. And lastly, we also found that RAS pathway mutations could be selected and expand during treatment with a JAK inhibitor, such as ruxolitinib, for example. So we have this initial complexity that will also change over time and make it difficult sometimes to catch the disease in its pure, let's say, beginning. So lastly, the currently available drugs like JAK inhibitors, for example, will target mostly the JAK-STAT pathway activation induced by the driver mutations. And these drugs, like ruxolitinib, fedratinib, that are currently available in France, for example, and tomorrow pacritinib and hopefully momelotinib, are all very good drugs to reduce the activation induced by the JAK2, MPL, or CALR mutation, but do not always address the molecular complexity of the disease. In addition, we haven't observed significant reduction in the JAK2 allelic burden, for example, or regression of bone marrow fibrosis in a large number of patients with these drugs, at least when used as monotherapy. So the future will probably increase the possible combinations between a JAK inhibitor and an additional drug that may target another pathway involved in disease pathogenesis. And for example, the two most advanced drugs that currently can target these additional pathways are navitoclax, a BCL-XL, BCL2 inhibitor, and pelabresib, a BET inhibitor. And preliminary results of early phase trials combining ruxolitinib with either these two drugs showed very interesting results in terms of biomarkers, such as reduction of the JAK2 mutation or regression of fibrosis in a higher number of patients than previously seen with a JAK inhibitor only. So maybe using combined treatment with JAK inhibitor plus another drug targeting an additional pathway will hopefully lead to some cure. In fact, we also have studied, for example, in our hands, the combination of ruxolitinib plus interferon alpha in patients with myelofibrosis, also showing in the so-called RuxOPEC study, very nice results in terms of reduction of the JAK2 allelic burden, for example, that was achieved in a similar proportion and a similar intensity that we could see, for example, before with interferon alone in patients with lower grade disease, such as polycythemia vera, for example. So altogether, I think that with one drug today, we cannot achieve cure of these diseases, but probably in the future, we may reach some better improvement in disease modification, for example, and opening the way for at least treatment-free remissions and hopefully cure of some patients. On the other hand, allogeneic stem cell transplantation obviously remains today the best way to cure our patients. But we have to keep in mind that this procedure is dangerous in patients with myelofibrosis who are often older, older than 60 at the time of diagnosis, for example, and often also have a poor condition due to the very highly inflammatory profile of the disease. As you know, as the disease progresses, these patients suffer a lot of inflammatory symptoms, such as fever, night sweats, cachexia, they lose weight, and they are very in poor condition sometimes, doesn't allowing to perform the bone marrow transplantation. In that perspective, we have tested the role of ruxolitinib treatment before allogeneic stem cell transplantation proposed as first-line therapy in a newly diagnosed patient in the JAC-ALLO study that was published by Marie Robin a couple of years ago. In that study, prospective trial, phase 2, we found that the disease-free survival at 12 months was 52% and 46% at 24 months. The overall survival was 68% at 12 months and 55% at 24 months. So these results are good, but not as good as that, showing that we still lost a lot of patients. And one of the important parameters to predict this survival was, of course, the type of donor. The survival was very good with sibling donors, but dropped dramatically as soon as an unrelated donor was used, and in particular when it was mismatched with the patient. So we have this curative option, but the allogeneic stem cell transplantation is sometimes difficult in patients with myelofibrosis, and often we say that it's probably the most difficult indication for this procedure that can save and cure many of our patients, but not all of them. So we need new therapeutic options to achieve such a cure without maybe transplantation.